Well, that's a great question. The staff adoption of high-tech equipment, and we've been using the Epic, for example, in our office for 15 years. One of the first practices to implement a very fast, efficient workstation type system. Patients love it because they know we're advanced. They see the flows increase, the wait times are less, but it's more the advanced diagnostics. So they know that we're actually getting the data we need on their eyes to make a good decision on what their problem is. And going back to the staff problem, they always adopt. They're actually trying to convince me to purchase another system at this meeting because they know how much it improves flow. Doing cataract surgery on post-refractive patients, and I've performed over 30,000 laser refractive procedures, and I have a handful of RK procedures, and it's a challenge because everybody's getting cataracts now that I originally did surgery on, which is a positive thing, I guess, for business, but the challenge is getting them as accurate as I did with the LASIK and the RK in the day when they had it done. And we look at, with our new OPD diagnostic technology, I can look at pupil size, angle kappa, I can look at spherical aberration, I can get all the corneal parameters that I need, and all those numbers are important for various reasons. To help select the proper IOL for these type of patients, as well as to be able to implement some of those data points from the cornea into the Ascaris website, for example, so I can get a more accurate IOL power reading. Ultimately, we always confirm with our intraoperative wavefront aberrometry, but the OPD-3 is critical in determining IOL selection for our patients. Well, that's excellent. We do many toric IOL lens implants, and at the time of surgery, obviously positioning is critical, but you need to know if it rotates the next day. Even day one post-operatively, when pupils are already coming down, or 1 week post-op, you don't have to dilate the pupil with the use of the OPD-3 to actually see the position with their retroillumination feature on the OPD-3, so I can know if a toric IOL is perfectly aligned or not, if I have to go back and do a rotational procedure to get it back on axis. First of all, we've had Epic for at least 15 years, and our flow from day one has improved. We have multiple technicians. It's great to have the technology. Our flow time between patients, the limiting factor now is just dilating the pupils. However long it takes to dilate a pupil, there's the flow as we're being analyzed now on the internet with all these websites grading your practice, and the biggest complaint by patients are wait time. And you have to set expectations, obviously, to tell a patient what you need, and we do a lot of diagnostics, so we'll tell them they'll be there for a couple hours for all our advanced diagnostics. At the same time, we need to maximize the flow with all the extra technology, be it an OPD-3, OCT, IOL Master, etc. And so our flow time and efficiency time has really been improved, and so far we've gotten some great ratings on the internet as a result. We started EHR almost a year ago, and the ease of transition with our diagnostics, specifically the OPD-3, was great. We have a second screen in all our exam rooms, which the best feature that I love with the EHR transition is I have a screen where I can pull up the internal OPD and total OPD, which for a patient means their corneal versus lenticular astigmatism, and I can convince them and show them we take out the cataract, you're removing the lenticular astigmatism, and you're going to be left with the corneal astigmatism. And just by showing them on the screen, with all that technology, they understand why they need a toric lens implant, for example. So our EHR integration was pretty much seamless. It was already a challenge as it is, but the system we use is very easy, and implementing and incorporating the OPD technology was really a one-step procedure, and patients really like being able to see what their eye tells them. The great thing is when you're looking at a lens implant, first you need to know if a patient's post-refractive surgery. If they had hyperopic LASIK, they're going to have a negative spherical aberration. If they had myopic LASIK, they're going to have a positive spherical aberration. But the beauty is you don't really know how much it is. And the OPD-3 actually will tell you exactly how much spherical aberration a patient has, whether it's a virgin eye, a post-refractive eye, or any other surgical treatment on the eye in the past, and you can actually help select which lens implant power based on the manufacturer and how much aberration correction you need by actually having the absolute number measured on the eye. Well, the biggest thing is flow issues. You improve flow, you improve efficiency. Time is money nowadays. The second thing is the advanced diagnostics. I can get an image on each eye 10 seconds per eye. And actually get 21 diagnostics from pupil size, scotopic, mesopic, angle kappa, spherical aberration, corneal topography, corneal versus lenticular astigmatism, retroillumination on a lens implant. There's so many so many advanced diagnostics in 10 seconds per eye. And most patients, when they're going from one machine to the other, especially when they're senior patients that already have dry eye, the diagnostics are not as accurate. If you put a patient on a corneal topography machine alone and then move them to another machine to measure pupil size and move them to another machine to measure wavefront aberrometry, by the third test their eyes are dry and the data is not accurate. So being able to get 21 diagnostic points in 10 seconds an eye and don't have any ocular surface issues to prevent good data acquisition is excellent. So that's probably the main advantage besides all the diagnostic data you get. But one machine does pretty much everything. It's really easy. So many times as an eye surgeon, we have the perfect outcome, at least in what I think is a perfect outcome. Patient seeing 20/20 or J1 and they're reading 20/16 intermediate vision, especially in our premium IOL, and you can't figure out why they're unhappy. Well, we did actually a small retrospective study, which I've published in a couple journals recently, which showed utilizing angle kappa, which is a hard measurement to get, and the OPD-3 device actually allows us to get angle kappa measurements. And the angle kappa measurements are excellent when you're looking at whether a patient should have a multifocal or an aspherical lens, non-multifocal technology, and helps us determine what's that fine line to determine the best outcome. And when we did a retrospective data, we found that angle kappa 0.4 or less was the best for a multifocal patient. Any angle kappa was good for an accommodating IOL. So, but without the OPD-3, I've never been able to measure that. And usually I can determine if somebody's referred in that's unhappy. I can tell if they have a high angle kappa. I could probably tell them that's why their technology, they'll reach 20/20 J1, they're unhappy.